So let's begin with pituitary adenoma. This is a benign tumor of the anterior pituitary cells. Of course, the anterior pituitary cells, they produce a number of different hormones. If the tumor produces hormones, we call that functional. And if the tumor does not produce hormones, we call that non-functional. Now, if the tumor is non-functional, then it will present with mass effect. And one of the classic presentations would be, for example, bitemporal hemianopsia. Now recall that the pituitary sits in the sella turcica, and that adjacent to the sella turcica is the optic chiasm. And so if the tumor was to press on the optic chiasm, this would result in bitemporal hemianopsia, or loss of peripheral vision in both eyes. Just illustrating this, if this is the two eyes here, and let's pretend they're looking at the numbers 1, 2, 3, and 4 here, when you see the number 1, it actually crosses over and then comes like this and then crosses over the nerve like that. When you would look at the number 4, it would come across like this and then again would come down the nerve and cross like that. When you look at the number 2, that would cross over here and come down like this. And when you look at the number 3, that would cross over here and come down like this. Now this here is the optic chiasm. So imagine that if you've got a tumor compressing the optic chiasm here, you're going to lose the ability to see number 1, and you're going to lose the ability to see number 4. And so here you can see that both eyes have lost their peripheral vision, and that's called bitemporal hemianopsia. Now notice that the number 2 never ran through the optic chiasm, and this field also never ran through the optic chiasm. Another complication could be hypopituitarism. If you have a tumor and it begins to compress the normal pituitary, then you would see signs and symptoms of loss of the hormones that are normally produced by the pituitary, and that's called hypopituitarism. And finally, a non-functional tumor could also present with headache. Now, functioning tumors are going to present with features based on the hormone produced. Recall that the anterior pituitary produces a bunch of hormones, and theoretically, a functional tumor could produce any of these hormones. However, the most commonly produced hormone is prolactin, and hence the most common type of pituitary adenoma is a prolactinoma. Now, when you have a prolactinoma, it's going to result in signs and symptoms based on the production of prolactin. And you're well aware of the fact that prolactin is important in the production of milk by the breast, and so you'll get galactorrhea. And in addition, recall that prolactin inhibits GnRH synthesis and release. Now, if you don't have GnRH synthesis and release, you're not going to get FSH and LH release. And therefore, if you don't get FSH and LH release, that's going to result in amenorrhea in females. So these are the two key findings in females. In males, a prolactinoma would result in decreased libido. Again, prolactin would inhibit GnRH release, which would then reduce the release of FSH and LH, and so that would result in decreased libido in the male. And at the same time, there could be headache due to mass effect. Now, it's important to note that males will not get galactorrhea, and that's because males don't have sufficient breast tissue for milk production. Recall that the functional unit of the breast is called the terminal duct lobular unit. Here's the terminal duct, and here's the lobular unit. Remember that the lobules contain these glands, which basically produce milk. Now, this lobular unit would develop in a female after puberty. However, males do not have lobular units in their breast. They simply have terminal ducts. And so because there's only a terminal duct, there's no ability to produce milk. And so again, a male would not develop galactorrhea. Now, the treatment of prolactinoma is dopamine agonists. Remember that dopamine from the hypothalamus normally inhibits prolactin secretion. And so if you gave a dopamine agonist, you would also be able to inhibit prolactin secretion, and actually the tumor would shrink. And so, for example, bromocriptine would be a useful dopamine agonist. In addition, you could also remove the tumor via surgery. The next type of adenoma is a growth hormone adenoma. Of course, this tumor would release growth hormone. If this tumor were to arise in children, it would result in gigantism, and that's because children have not yet fused their epiphyseal growth plate, and so they would get linear growth of bone in response to the excess growth hormone. Adults develop acromegaly, and acromegaly refers to an enlargement of the bones of the hands, feet, and jaw. In addition, they get growth of visceral organs, for example, the heart. In fact, cardiac failure is the most common cause of death in these patients. They can also develop an enlarged tongue. An important high-yield association here is that growth hormone adenoma is often associated with secondary diabetes. Recall from physiology that growth hormone decreases glucose uptake into cells, and so therefore if there's a lot of growth hormone around, glucose will not be taken up by cells, and secondary diabetes will develop. The diagnosis of growth hormone adenoma is made by looking at elevated growth hormone levels and elevated insulin-like growth factor levels. Recall that one of the effects of growth hormone is to go to the liver and cause increased production of insulin-like growth factor, and it's actually the insulin-like growth factor that mediates the growth of tissues. and so therefore you would expect insulin-like growth factor to be elevated. Were you to give a patient oral glucose, normally you should be able to suppress growth hormone release. However, oral glucose would not be able to suppress growth hormone if there was a growth hormone adenoma. A potential treatment is octreotide. This is particularly high yield. Recall that growth hormone releasing hormone actually goes to the anterior pituitary, and in response to growth hormone releasing hormone, the anterior pituitary then will secrete growth hormone. The way by which octreotide works is that it is a somatostatin analog, and it blocks the response of the anterior pituitary cell to growth hormone releasing hormone. And so therefore you would not be able to generate the production of growth hormone. You could also give growth hormone receptor antagonist to block the effect of growth hormone, or of course surgery could be performed to remove the tumor. Other types of functional adenoma include ACTH cell adenomas. They would secrete ACTH, resulting in Cushing's syndrome. We'll cover this in more detail when we talk about Cushing's syndrome in a later section in this chapter. Of course, there can be a TSH cell adenoma, an LH-producing adenoma, and an FSH-producing adenoma. However, these are rare, and so we won't go into more detail here. Now, shifting gears a little bit, moving to hypopituitarism. This is where you have insufficient production of hormones by the anterior pituitary. Symptoms usually don't arise until you've lost greater than 75% of the pituitary parenchyma. Causes include pituitary adenoma. That would be a common cause in adults. The idea here is that the pituitary adenoma would grow and it would compress the normal pituitary, which would then cause loss of the tissue of the pituitary. Another possibility with a pituitary adenoma is that you could get bleeding into the adenoma. That's called apoplexy. And when you get bleeding into the adenoma would rapidly grow and would compress the normal tissue. An additional mechanism of hypopituitarism would be a craniopharyngioma in children. Again, the same thing, the craniopharyngioma, which we'll cover when we do CNS, normally arises within the region of the sella turcica, and so it could compress the normal pituitary tissue. Sheehan syndrome is particularly interesting and particularly high yield. Recall that during pregnancy there's a high demand of hormone due to the physiology of the pregnancy, and so the pituitary gland actually doubles in size. However, although the gland doubles in size, the blood supply does not increase that much, and so therefore that leaves the pituitary relatively susceptible to infarction. Now imagine that if a woman gives birth and loses a tremendous amount of blood, it would be very easy for the pituitary to undergo infarction, and that's called Sheehan syndrome. Now what's interesting about Sheehan syndrome and what's high yield for board examinations is that these patients present with poor lactation and loss of pubic hair. Loss of pubic hair is a very important association with loss of pituitary function, and that's because pubic hair is dependent on androgens, and those androgens would arise due to LH, which arises from the anterior pituitary. So again, Sheehan syndrome is particularly high yield. Empty sella syndrome refers to a circumstance in which the sella is empty and the pituitary is missing. It can occur in two ways. It can occur due to secondary trauma to the pituitary, in which case the pituitary would be damaged, or it can occur in a primary circumstance where there is a congenital defect of the sella, such that you get herniation of the arachnoid and the CSF into the sella, which then compresses and destroys the pituitary. Again, the idea here is that if this is the sella with the pituitary sitting in it, recall that attached to the sella here, the bone of the sella is going to be the dura, and then there's going to be the arachnoid here as a second layer, and then of course you've got the pituitary sitting here, and attached directly to the pituitary would be the pia. Now, if there was herniation of arachnoid and CSF into the sella, that would compress the normal pituitary, and as it compressed the normal pituitary, the pituitary would then be destroyed, resulting in something